So as my introduction says, I did do my dissertation research in Nova Scotia, Canada. The province of Nova Scotia recently put a lot of money into 11 brand new long-term care facilities in the small house model. I'm going to be talking about that further. And this talk today is just going to be a piece of my research. This morning I talked about social interaction, and yesterday I had a post on the resident perspectives, but today I'm just going to be talking about caregiver perspectives. And I just wanted to start with this quote that I found from JFK, 5 decades ago, just talking about our role in society to create places for vulnerable populations. And, society in short can and must catch up to science. And I think that's really important for us all to remember. Our work is very important. And we've all seen that picture somewhere in person or in a magazine. And we think it's a caregiving environment, but that is that care. So that, to me, is an anomaly. And anomalies are questions and issues that can no longer be adequately addressed by the current system. And what we found is that, when tensions are created around an anomaly, things happen. And what's happened in Nova Scotia is the continuing care strategy, which was developed in 2005 and 2006. And within that strategy, 10-year strategy to improve the continuing care system in the province, cost of $122 million of government funds for the first 4 years of the strategy, and that cost included 11 new continuing care facilities built in the small house model. So what is our role as social scientists? We're looking at ways of identifying the most effective ways to organize, manage, and deliver high-quality long-term care. And it's really important to differentiate between the population's care needs and care objectives to maximize the relevant precision of their work. And specifically in the small house model, we're really changing the organization of nursing care. We're turning it upside down, and it has to be sort of encompassed by the entire organization and all of the organization's employees. And in this case, we're talking about the caregivers and their interaction, which really can be called a mutual reciprocal action or influence between the client and the caregiver. So research into caregiver interaction must therefore be multifaceted with a view into the world of the caregiver, the resident, and the social environment in which they both inhabit. And my background is architecture, so I really am looking at sort of the environmental gerontology factor of this, the individual in their social spatial environment. So we talk about the small house model. What is it? It can be a lot of different things, but one of these things that definitely is a self-contained, residentially scaled, attached or detached living community for 8 to 12 long-term care residents with easy-to-navigate residential scale and a no-fail secure environment. An environment that fosters a sense of community with various settings for social connection and interaction and withdrawal. To really try to reestablish meaningful activities of daily living, to provide a renewed sense of autonomy, encourage choice, control, and independence. So in my literature review, looking at the definitions of the small house model, again, it's the small groupings, residential scale, but it's also the culture of care, person-centered care, focus on the individual. We've heard about that earlier in previous talks. And the flattened hierarchy in the nursing and care staff. And all of these factors on this table were part of the guidelines that the province gave to the 11 providers. It said, this is what we want to see. So in the United States, we just don't really have that. We don't have those large sums of money thrown at this new kind of system or organization. So there is a lack of resource to inform us. And so we're often left guessing, what's good, what's going to work, what's the right answer, is there a right answer? And so really the purpose of my research, the entire case study research, was to understand what happens when everybody's on the same page, the government, the provider, the family members, the caregivers, and the residents. I actually spent time in a facility that was built prior to the continuing care strategy. Today I'm just talking about the facility that was built afterwards. But I did a number of face-to-face interviews with staff, residents, family members, management, and provincial leaders All interviews took place in public areas, audio tape transcribed, and I did some document review that pertained to the continuing care strategy, and did photography, transcribed the interviews and field notes and data, and rearranged and coded them for themes. I'm going to talk a little bit about Nova Scotia. It is the most easterly province in Canada. It's a poor province, and very small, about the size of West Virginia, with a population of less than 1 million. Halifax Harbor, which is where I spent most of my time, is the second largest natural harbor in the world, and the population is about half of the province is in this area. This is the facility that I spent time at, Stonebridge. When it opened in 2009, the resident population was 49, but there were actually 50 beds available. And I know that it's kind of hard to read, so I just want to highlight. So we have Cottage 1 and Cottage 2. Cottage 2 was the memory care cottage, and then administration and services and the community center were on this screen over here. And so each of these cottages had a front door. It was a self-contained household. And level 2, again, same pattern. So the emergent themes with respect to the caregivers, and as I say, I had a lot of data about all the people that were actively involved, but we're talking specifically about the care staff. Emergent themes were teamwork, choice, risk, and autonomy for the residents, the physical and organizational environment, and staff empowerment. So what I got from the care staff was really how much they saw a change in the way that they were giving their care in this new small house model. They were really torn where they had been working before. They were pushed, they didn't get to know the residents. They had 8 residents one day and then a whole new set of residents the next day. You didn't get to know them, you called them by the room number. It was the antithesis of person-centered care. And you're forced to do everything yourself. You're afraid to ask for help. It's institutional, it's the medical model. At Stonebridge, they're cross-trained to do everything within the cottage. They do not move from cottage to cottage. They are the cooks, they are the cleaning staff, they are their care staff. They do help with ADLs in the morning. So it's a lot of work, it's a lot of time. And a lot of the CCAs commented that, a lot of people come in here and get started and they say this is too much, and they leave. It's a little bit much, and it's very different from the unionized care that they were giving in nursing homes, of the older type of nursing home. But the ones that stayed, they knew it was worth it. They understood the benefit of getting to know the residents. They also liked the fact that they were able to self-schedule within the cottage. They could make up their own schedules between the caregivers. They didn't have to deal with the downstairs management, and that was really a important benefit. And but they realized that you had to have a good team to make that work. You had to have people that were willing to be flexible. But what they also found was that, especially at night, staff shortages, when they were down to 1 CCA per cottage and a rotating RN and LPN. And if anything happened, it was kind of like all hands on deck, we got to make this work. So the staff shortages were particularly evident in the evening. Now on to choice, risk, and autonomy. The choice that we have in person-centered care was really important to the care staff to be able to allow the residents to make choices with their day. And they talked a lot about how they felt about waking people up when they worked at those previous communities, and how hard it was for them to go in and shake somebody out of bed when that person just wanted to sleep, And then people would come into the dining room and they didn't get to eat because they missed the meal. So at Stonebridge, it's letting them be who they are is so important. This is their home. So really changing that perception of this is my workplace to this is the home of these residents. And they're allowed to make the choices that they want to make. But the sort of counterbalance to that is the RNs are saying, you know what, those lifestyle choices were sometimes the reason why these people ended up in long-term care in the first place. Letting people sleep through when they're supposed to get their medication, or the resident that just says, I'm not going to do it because it's the Eden alternative. I see Rosalie laughing. So this was something that really struck me, is this sort of balance of the day-to-day care staff and their impression of allowing residents to make their choices, and the RNs and this sort of butting heads, you know, well, in actuality, you shouldn't let them sleep all day. You should get them up because they need to eat, they need to exercise.